Thank you very much. Thank you, Peter, and good morning, everyone. Again, I'd like to thank Professor Papan and his colleagues for inviting me to come to talk to you today. So this is PASS's prologue. So in the 1990s, there was a sexual revolution. There were increasing STIs. Here you can see the curve for gonorrhea and syphilis. It looks like the curve for gonorrhea in the US hasn't gone up so much to prior levels, but you can see the syphilis taking off. But all epidemics are local, and if you start looking at local epidemiology, you see some worrying trends. So here are the data from my state in Massachusetts. You can see both gonorrhea and syphilis rates have gone up and achieved levels very similar to those that we saw in the 1990s. In particular, and very similar here in Southeast Asia, the epidemic is increasingly disproportionately among men who have sex with men and other sexual gender minority individuals, including transgender people. And the other thing that we noticed when we looked at the data in Massachusetts was that a very small number of people are associated with a very high percentage of the STIs. So really focusing on people at high risk for STIs is a key part of epidemiologic control. Globally, we're talking about an epidemic where there are more than 300 million new STIs if you think about the 4 curable STIs. These are infections that we should be able to control, trichomoniasis, syphilis, gonorrhea, and chlamydia. Yet you can see very high rates in every part of the world. If you look at the map, the prevalence in Southeast Asia doesn't look to be that high, but as you know, because of the highly dense population, the absolute numbers of new STIs here in Southeast Asia actually is quite high and is a burden of infection for individuals. The other area which we're concerned about, particularly with regard to gonorrhea, is the emergence of drug resistance. And we're all fearing the day when there'll be a strain that will not be treatable. And several of these more drug-resistant strains have been first detected in various countries in the Western Pacific. And so certainly the concern for the region, I think, is very significant. This is not a regional problem, though. These are data from an NGO in Lima, Peru, and you can see very high rates of syphilis, very high rates of HIV, particularly in men who have sex with men and transgender women. This is not limited to Latin America. If you look at men who have sex with men in South Africa and Nigeria, again, high rates of gonorrhea, chlamydia, and syphilis. And here in Bangkok, data from the HIV-NAT consortium showed basically in Bangkok, just over a 6-year period, if you do the aggregate prevalence of people being tested at the Siloam Community Clinic, HIV prevalence high, syphilis prevalence high, but if you unpack and actually go year by year, you can actually see very significant incidence of both of these infections. So clearly this is an acute problem here in Bangkok. Also in South Asia, work that I and my colleagues have done in India, it's very important when we talk about STIs and sex and sexuality that we really focus on behaviors and try to be as non-judgmental as possible. So we did a study in Mumbai with an NGO, the Humsafar Trust, and we used respondent-driven sampling, meaning that we selected individuals who were seeds. They were given coupons to incentivize their partners to come in and get tested. And we found that men who were married to women and men who were not married to women, when we looked at the STI rates and HIV rates, they really were comparable, that there was not a significant difference in HIV, syphilis, gonorrhea, or any STI, particularly when you adjusted for the RDS. There's various techniques that you do to adjust the weighting. So basically, it's not who you think you are, it's not how you present yourself in society, it's what you do that puts you at risk for STIs. So why is this happening? So this cartoon really points out the fact that the historical pattern was saying that STIs are driven by 3 factors in terms of their interaction with HIV. There's biology. We know that STIs may manifest themselves with local mucosal inflammation or with ulceration, either of which can increase the susceptibility to HIV. But there's also behavior. To get the STI, an individual has to engage in condomless sex, so the behavior puts one at risk for HIV. And there's the epidemiology. People acquiring STIs may be part of social networks where there's high prevalence of STIs, so even without having lots of partners, just by being in a high-risk network. For example, going to a sauna, a bathhouse here in Bangkok will put you at high risk for STI, even if you only have one new partner. So this was the classic paradigm. Well, what's happened now in the current era, we have PrEP and TASP, and in point of fact, there's an unlinking of this epidemiologic synergy. In other words, somebody who's highly adherent to HAART, who's HIV infected, is not going to transmit HIV, but if they engage in condomless sex, they may acquire STIs. Likewise, somebody who's on PrEP will not be at risk for acquiring HIV in general if they're highly adherent to PrEP. So what we have instead now is the new paradigm, which PrEP and TASP are associated with this increasing rate of new STIs. But as I mentioned yesterday, we can't demonize one intervention or another. This is a new era. We have to learn how to use the information and be more informed clinically. Certainly we know that rectal gonorrhea and syphilis are highly predictive of future HIV infection. These are data for the US. And moreover, having recurrent rectal STIs is particularly predictive. So these data from the Centers for Disease Control in the US basically said your risk, if you have 2 rectal infections, goes up enormously. So somebody in that situation, if they've not been tested for HIV, that's malpractice. And in this day and age, I would say if those individuals are not offered PrEP, that's malpractice as well, given the high risk of becoming HIV infected. So it's very complex why this is happening, and we can't just blame one single factor. Certainly there's individual behavior. So some individuals may have multiple partners, and that may put them at particularly high risk for HIV. But we can't ignore for the key populations that there are biological factors as well. And what makes this complicated when we think about STIs are that there are different risks for different STIs, and I'll talk a little more about that in a minute. The other thing we have to keep in mind, both with regard to HIV and some of the other STIs, is that anal intercourse puts an individual at particularly high risk because of the mucosal biology, and there's work now going on that may suggest that microbiome factors may play a role as well. The other issue for men who have sex with men, and in some cases for transgender individuals, is role versatility. So the same individual may be able to be receptive and acquire HIV or rectal STI, but may also be able to be an insertive partner as well. Another concept that we have to think about for STI control are networks. So the per contact individual rate may change just by virtue of being in a network. If one's partners are in an area where there's high HIV prevalence, having the same number of partners as a person having partners in an area where there's lower prevalence of the STI or HIV, that may connote different risks. There's another concept called assortative mixing. So in the US, we see this in particular with racial and ethnic minorities, that people are more likely to have partners from within their own group. But this may also manifest in terms of socioeconomic issues. So people may be more likely to have sex with partners in a slum area, or if they're poor, because they may have less opportunities to travel and to meet partners from other socio-demographic groups. So this tends to concentrate the epidemics. And again, very important to understand these dynamics so that we can be more effective in our STI control. And then obviously there also are sexualized venues. Historically in the past we thought of these as physical venues, so bathhouses, saunas, but now we have the electronic media, the social media, and these are places where people can efficiently meet partners. So we have to gear our HIV and our STI control efforts around these venues and think about how do we work with owners of saunas, how do we work with apps to be able to get people more readily tested, getting them into treatment and care. And then lastly, and something I'll go into a bit, we as clinicians really have a major role, and societally we have to think about a role in how we may be facilitating some of these problems. So issues like homophobia, transphobia, bullying, people growing up in a non-affirming environment, this can lead to developmental stress, developmental stress can lead to depression, lack of self-efficacy, and increased risk. And certainly criminalization in some societies and discrimination in healthcare settings means people avoid coming into care. And because many of these STIs are asymptomatic, the delay in the time to care means the increased amount of time that somebody may be transmitting to a potential partner. So just to put a finer point on some of these issues, so in terms of the different practices that transmit different infections, it's very important for us as clinicians to understand that HIV prevention messages around safer sex are going to be different than some of the STI prevention messages. So that's primarily because HIV is particularly transmitted by penile rectal sex or penile vaginal sex. But syphilis can be very readily transmitted by fellatio, either or cunnilingus, either being the person performing or being the person receiving. Similarly, gonorrhea and chlamydia transmission, there's some debate about whether they are readily transmitted, and there's even a debate about kissing in the transmission of gonorrhea. And in point of fact, in Melbourne, Australia, Kit Fairley and his colleagues are conducting a clinical trial looking at whether Listerine, whether antiseptic mouthwash, is useful for post-exposure prophylaxis to decrease gonorrhea. So this will be a very interesting study, but it really highlights the fact that we have to educate patients and certainly educate ourselves that some of these other STIs are much more efficiently transmitted. So an individual who's on PrEP, an HIV-infected person in care, has to understand that they may be asymptomatic, but some of their behaviors, which may not transmit HIV or may not put them at risk for HIV, may put them at risk for these other infections. The other issue is we should certainly still promote condoms for individuals who are interested and want to use them, the same way we talk about harm reduction for people who inject drugs. But we also have to understand that certain infections, viral infections, condoms are not necessarily completely protective as well. So we don't have perfect tools, but we have to use the ones that we have, but we have to be sophisticated about our education and our messaging. One little aside, there's some very interesting biology now going on at Emory University, where they did a study of HIV uninfected men who had sex with men who reported condomless receptive anal intercourse. They enrolled people who had a known HIV uninfected partner, and they did rectal biopsies. And they basically showed that the rectal mucosa changes dramatically in response to exposures to semen, and a lot of inflammatory markers and a lot of changes in the rectal microbiota. So it's early days in terms of this research, but part of our safer sex counseling may be just educating patients about condomless anal sex may really alter the mucosa. And again, in this day and age, this may mean, particularly for HIV uninfected individuals, they need to be very highly adherent to PrEP if they're going to want to protect themselves against HIV. I mentioned the issue of sexual positioning, and we don't have good data from around the world, but these are data from the United States from a study called the National Survey of Family Growth, and they had a subset, large enough subset of men who had sex with men, and they found that 46% indicated that in the prior 6 months they were both a receptive and an insertive individual. So this issue of role versatility is extremely important, and the reason this is relevant, and this gets into a major public health discussion, is the issue of what we should be doing in terms of screening the different mucosal sites for the STIs. The other point, again in the US, but I believe there are certainly data here from the region as well, that in the era of PrEP, in the era of treatment as prevention, we are seeing more condomless anal sex, and have to take that into account as we do our screening work. The other issue to take into account is the use of electronic media. And again, we think of this as a more developed world context, but these are data from men in sub-Saharan Africa, and particularly if you look in several of the countries, it's the younger MSM who are using the internet more frequently. And this is both because we have the technology, but there's another phenomenon. This is how the social interacts with some of the other issues. So studies from the group at Johns Hopkins, Steph Barral and Chris Byer's group, looked in both Lesotho and in Swaziland, and they found some very interesting risks, that the people who were more likely to meet their sexual partners online, they were more afraid of going out in public, they were more afraid of stigma and of violence. And these individuals who met partners online were also more likely to be HIV infected. So clearly, doing more of our outreach and our media online, and certainly there have been some very creative efforts here through the Thai Red Cross, Adam's Love, and other social media campaigns, which is exactly where we should be focusing. These new technologies are challenges, the fact that people can meet partners online so easily. I can take out my phone now and tell you within a few feet about who's available and interested, and that's certainly a challenge. But at the same time, we can develop apps to work with people to educate them about HIV and STI risk, and there are a number of them that I'm just highlighting here. So yes, there are the apps, but there also are these new tools. None of them are ready for prime time, but this is, again, where we really should be putting a lot of our efforts. And there are a number of clinical trials underway now to look at whether young people will load the apps on their phone and whether this will motivate behavior to increase screening. The other point I'd like to make is that the physical venues still exist. So in New England, there's a large bathhouse in a town near Boston, Providence, Rhode Island. So we did a study. We provided on-site testing for HIV, hepatitis C, syphilis, gonorrhea, and chlamydia, and we found substantial rates of HIV and HCV higher than any other site in the local community. So testing in the bathhouse clearly has value. The other thing we found in the study, which is very concerning, was we asked people what they actually did in the past 3 months. So UA is unprotected anal sex, UO is unprotected oral, and we found that a substantial number of people who said that they had condomless anal sex didn't think that they were particularly high risk for HIV. So the other challenge in these venues is to try to educate people about their risks, so to get them tested, educate them about their risks, provide them with the tools to protect them against future infection. I showed this slide yesterday. I just wanted to show it again about our own experience at Fenway. Dramatic increase in the bacterial STIs, and I still submit to you that the fact that in 2015, in a place where PrEP was available since 2011, that there's such a large number of people who are HIV uninfected, not on PrEP, developing these infections, again, is a bit of a disconnect and a challenge, even in a place that I think of as trying to emulate best practices. So let's get back to the epidemiology of how STIs spread. So this equation from Anderson and May says that the reproductive rate of any epidemic is a function of the infection per contact, the contact per time, and the time and duration of infection. So that first variable, infection per contact, that's infectiousness. So with regard to HIV, we have treatment as prevention. So that makes people who are HIV infected less infectious. Contact over time is number of partners, and time per infection, that's the one I want to really focus on right now, which we call D. So this is sort of a classic American dessert, triple scoop of ice cream. And the reason I'm showing this to you is that part of the effort has to be the triple scoop. We have to test people who are sexually active with NAT testing for the urine, which is a very easy and non-invasive way to get a good specimen. But rectal testing is extremely important as well, and oropharyngeal testing, because even if the oropharynx may be asymptomatic and not be a particular problem for the patient, it can be a reservoir for further transmission of these infections to other partners. But at the same time, we also, in the US, when we say the dessert is really complete, we say, and there was a cherry on top. So the cherry on top means that at the same time that you do STI screening, you want to screen for HIV as well with the 4th generation test preferably. You want to test for syphilis, and you also want to test for viral hepatitis. There are lots of new technologies for increasing this D, to increase the screening rates. So these are data presented from Tim Mintz and colleagues, and basically looking at the acceptability of home self-screening of all 3 orifices. And you can see very high rates of acceptability. Only 3 people said that it was uncomfortable, and you can see that the instructions are easy to follow. We're currently involved in a study now in the US looking at home self-monitoring for PrEP, which involves screening all 3 mucosal sites and doing a finger prick to test for syphilis on a quarterly basis. Some people have wondered if some of these studies have a selection bias, where we're doing more testing, and because gonorrhea and chlamydia can have been around for a long period of time, maybe we're just seeing more cases, particularly at these extragenital sites, because we're doing more testing. So one of the big commercial laboratories in the US that does a lot of screening is called LabCorp, and they indeed have had a major increase in the number of positive results for rectal and pharyngeal testing and more infections being diagnosed. But the rate of syphilis diagnoses has also increased over time, and we wouldn't necessarily expect a backlog of syphilis when the rate positivity has increased. The other thing that has been going on in the U.S. is that with the passage of the Affordable Care Act, there's been more STI screening. So there probably is a bias that we're seeing more STIs because we're doing more screening in many places, but the true prevalence is also going up at the same time. So it's yes, yes, and related. Our own experience here, just to show you at Fenway, is as we've started doing more screening, we're doing more detection, and you can see in blue the rate of detection of rectal infection has gone up enormously. So this is a really important place to do our screening. I want to emphasize in this talk, we've really been focusing on the bacterial STIs because they are curable and they're highly prevalent. But just as clinicians thinking about STIs, there are other issues to think about as well. So they're the viral STIs, so certainly herpes simplex type 2 and being sophisticated about diagnosis in people who are having recurrences using suppressive therapy, that's extremely important. HPV, hepatitis A and B are all vaccine-preventable diseases. So I know that in some settings these vaccines may be expensive, but the cost-benefit has been proven immeasurably that these are safe and effective and really should be incorporated. I'll mention hepatitis C because unfortunately we are seeing more sexually transmitted hepatitis C in Europe, in the US, and now I understand here in Thailand as well. There are other infections. The reason why we have to get a good sexual history, they're behavioral infections. So people who engage in anal sex, particularly if they engage in oral anal sex, they can acquire enteric infections. So that may be an important part of screening. We've seen in people who go to gyms and sometimes have abraded skin may have MRSA and may transmit MRSA to their partners. So not a classic sexually transmitted infection, but something to be aware of in somebody coming in with a rash. There have been reports of people who've gone to saunas in the U.S. who've developed meningococcus, respiratorily acquired infection, but can be associated with outbreaks. Traditionally in the U.S., young people in college campuses in dormitories, but there have been these cases in men who have sex with men. And so, again, if we see a case of somebody with meningococcus, knowing where they've been in their contact is extremely important for public health purposes. And two infections that have been shown to be sexually transmitted, Mycoplasma genitalium, a hard to treat infection, but a cause of non-gonococcal urethritis, so certainly something to think about. The drug moxifloxacin has been associated with benefit for some individuals, so one thing to think about. And just an emerging infection, the Zika virus, and again would be a particular concern when people acquire it sexually in the urethra. It's usually not symptomatic, but particularly in somebody who may be having female partners, the impact for infant is important. So certainly knowing whether Zika is prevalent in a community and doing surveillance work may be important as well. So these are data from the US just to show the increase in the sexual burden of hepatitis C. The associations here, and my understanding also, the association in the US, and I also understand here, have been people who engage in group sex, so there may be more sexual trauma, potential blood association, individuals using crystal methamphetamine, and again, it may be people partying harder may acquire hepatitis C. But certainly people who endorse those histories to you when you take a sexual history would be individuals you'd want to test for hepatitis C in the current era as well. Another way to improve screening is to be more sophisticated. So Dr. Posniak, Dr. Hill have talked about, alluded to the Dean Street Express, really very sophisticated drop-in clinic in London using new technologies. So the clinic involves having a touchscreen interface of asking the intake questions. It has a NAT machine in the basement so that it can do rapid turnaround and give people answers in 90 minutes, and then send people text messages about their tests being positive. Many other places around the world are trying to do this. Here in Bangkok, you have the Tangerine Clinic, you have other innovative programs, and I think we have to think about how to use the new technology more effectively to get people in and get them tested and through more rapidly. I alluded to the fact that internalization of societal rejection can have very profound health outcomes. And these disparities can lead to avoidant behavior, can lead to other clinical conditions. So as clinicians, we have to realize that the classic social cognitive model, if we want to prevent people acquiring STIs or HIV, we have to realize condoms may reduce pleasure, but educate them about the benefits. We have to work with peer support. We have to increase self-efficacy, and that may lead to safer sex and adherence. But all of these things get imploded by depression, anxiety, and mental health problems. So having the ability to refer people to appropriate counseling is another effective STI strategy. And we have to keep in mind that for some people in marginalized communities, for us as HIV specialists, this is the way we see the world. The way they see the world is this is just one thing about many that really drive the infections. And if we're not dealing with some of the other drivers in their lives, we're not going to have effective traction. Here, for example, are data from Lesotho, and the data basically say if you're a young MSM in Lesotho and you endorse a history that suggests you have depression, you're much more likely to have an STI and you're much more likely to have HIV. So part of STI control is behavioral health control. In India, we're doing a project looking at how we can support resilience, working with peer support groups to see whether that is going to lead to an outcome that will decrease HIV and STI incidence. So we're in the third year of a 5-year study, and hopefully will show efficacy. We as clinicians have to own up to the fact that these are data from the US, but I think these data are generalizable. There's a recent study from Malaysia that found similar data that LGBT patients found that providers were using excessive precautions, that they felt that they were blamed for their health status, that the providers were harsh. Transgender patients reported being harassed in a doctor's office or being denied health care. And these prejudices, these threats, including criminalization, lead to avoidance of care. And there are models of education. So a shameless plug, we have a website funded by the US government, lgbthealtheducation.org, that has a lot of tools to help clinicians be more familiar, to be able to be more culturally competent in providing sympathetic care. So in conclusion, I just want to emphasize the main theme of today is screen, screen, screen. We have effective technologies. I understand that NAT testing is expensive, but there have been numerous analyses suggesting that it can be beneficial. Some people have done studies looking at pooling, where you use one swab to try to get specimens from all 3 orifices, and then you'll treat based on a single positive result. There are other creative approaches that people are investigating, but certainly thinking about how we can screen more is important. Thinking about how we can create culturally competent and appealing services, leveraging new technologies like the Dean Street Express kind of model, and bringing the testing out to the community, so testing in places like saunas. There are 3 things I just want to put on the horizon that there really is not time to go into, but there was one study embedded in the IPER-GAY PrEP study looking at post-exposure prophylaxis for STIs with doxycycline. So these were people, if they had condomless sex, would take doxy after sex. They did show a decrease in a composite endpoint in decreased STIs, but they did not show an effect on gonorrhea. And there's the concern about selection of resistance. The study has not been fully replicated yet, so it's not part of routine guidelines, but it is certainly something worth considering, and whether it's a study to replicate here in the region is worth discussion. There are some new drugs on the horizon. Zoliflodacin is the next one coming down the pike, which may be useful for antimicrobial drug resistance. But as you heard just before from Dr. Posniak, these are not magic bullets, because particularly in an HIV setting, we have to be sure about drug interactions. So that is still early days. And there was an interesting finding in New Zealand that people who were vaccinated against meningococcus type B, the subset of MSM in that group, had fewer cases of gonorrhea. That led the manufacturer, GSK, to think maybe we have an effective gonococcal vaccine, and there's been more interest in gonococcal vaccines now in this kind of thinking. So there's lots on the horizon. I want to thank some of the colleagues who contributed thoughts and slides. Again, call your attention to the website that I'd mentioned, and thank you very much for your attention.